We're taking this, 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 we're taking with a pinch of salt.
Ladies and gentlemen, welcome to another episode of A Pinch of Salt, the ERA podcast in which we try to provide our audience with clinically relevant questions and answers. Today we'll be tackling a difficult subject, and that is monoclonal gammopathy of renal significance, or MGRS as it is called in short. You can expect to hear about the diagnosis of this disease, how to identify the clone responsible, how to treat patients in general, as well as perhaps those with no detectable monoclonal antibody in the serum. These are the most difficult ones, I guess, and much more. With us today to help us unravel these issues is Jolanta Małyszko. Jolanta is the head of the Department of Nephrology, Dialysis, and Internal Medicine at Warsaw Medical University. And she has a long-standing interest in this field and has published in it as well. Jolanta, welcome to A Pinch of Salt.
Good morning, Andrzej. Good morning, everyone. Thanks a lot for the invitation, and greetings from I would say the like sunny and much more spring in Warsaw today.
Yes, it's actually the same here. It's nice and warm and sunny. So
it's quite unusual for this time of year.
Probably, yeah. So I would like to ask just the first most basic possible question, which is, what is monoclonal gammopathy of renal significance?
Thanks a lot, Andrzej. And honestly, I think we need to start about saying just a few words on monoclonal gammopathy of undetermined significance, which is plasma cell dyscrasia under the threshold criterion of protein M levels and a bone marrow infiltration less than 10%, with no disease-related end organ damage. So when there is no organ damage, it's just MGUS. While MGRS, so monoclonal gammopathy of renal significance. So there is a patients who are at risk of developing progressive kidney disease. So in MGRS, there is a direct or indirect kidney injury caused by a monoclonal immunoglobulin produced by either B cell or plasma cell clone, and it does not meet the current hematologic criteria for therapy. So it may lead to loss of function and ultimately renal failure, and it's usually secondary to plasma cell or B cell clonal expansion or complement dysregulation. So this is, I would say, very tricky because, well, in MGUS, we just have protein M, some kind of a bone marrow infiltration, and no signs of organ damage. With MGRS, we have a kidney damage. And what is the much more, I would say, challenging part, that this definition, it means that MGRS does not meet criteria for overt or symptomatic multiple myeloma or lymphoproliferative disease.
Yeah, so we could
possibly... Let's make this disease so special, I would tell. So
I
from
would say it's very special too.
Yeah, and from the clinical perspective, it could be acute kidney injury, subacute kidney injury, chronic kidney disease, proteinuria, nephrotic syndrome, electrolyte abnormalities. So generally, we have the whole portfolio of nephrological disorders.
True, yeah. So in a way, we could perhaps say this is non-malignant monoclonal kidney disease.
Yes.
The distinction, of course, is important because malignant diseases already have an established therapeutic protocol. We know what to do with that. But non-malignant, that's more tricky. And perhaps AL amyloidosis without multiple myeloma is the most known and common of the MGRSs, right?
Yes, and also we also can suspect MGRS with smoldering multiple myeloma, Waldenström macroglobulinemia, or even monoclonal B cell lymphocytosis. And from our nephrological perspective, it's like unexplained kidney function impairment with or without proteinuria. So in patients with this unexplained worsening of a kidney function, with or without proteinuria, we should have I would say, the red flag, like alert. Oh, well, maybe it's MGRS. And we have to think about, we have to screen.
Yes. So when we do find MGRS, what we want to exclude first is the hematological malignancies, the ones that you already mentioned, multiple myeloma, Waldenstrom, or other lymphocyte B proliferative diseases. So how do we do that? Which are the usual diagnostic procedures that you do to exclude a hematological malignancy in these patients?
First of all, what we are doing in our clinical practice, we look for serum free light chains. So we do also the urine electrophoresis, immunofixation electrophoresis, and if we even do have negative immunofluorescence, it does not exclude clonal pathology, which makes the disease absolutely tricky.
Yes, that's commonly, I would say, in my experience, in monoclonal gammopathy of renal significance, where you have a proliferative glomerulonephritis, where you don't even have a monoclonal antibody in the serum, but you have it in the kidney, or
Yes.
at least we know it's a monotypical antibody, like only IgG1, only IgG3, which doesn't really say that it's a clone, right? It's not necessarily a clone. And even to be more complicated, a clone is a normal part of the immune system. We always get clones when we get infections, right? So how do you unravel this position, this situation?
Well, in general, when do we have, like, from the clinical perspective, when do we have the impairment in kidney function plus minus proteinuria? Usually our thinking is, okay, well, let's do, in particular in elderly patients, let's go for light chains, for immunofixation, but we also think about a kidney biopsy. So this is also as a part of the current diagnostic strategy. And we are fortunate enough that we are in a big centers with a high volume. We have the very good or excellent nephropathologist. So we have the possibility to have the results, at least I would say the first results of the kidney biopsy, sometimes even within 1 or 2 days. And of course, we have to wait for electron microscopy, but we do have availability. So this is, I would say, the one point. And also, what we are looking at kidney biopsy, like some kind of a restrictions or a deposition. And of course, we have sometimes there were some changes were relatively misleading, like atherosclerosis, diabetes, but they could coincidence. They could have a coincidence with the restriction of the clonal chains, and that's why I think that in MGRS, the primary kidney damage is due to the abnormal deposition of or activity of monoclonal proteins in the kidney tissues. And also the kidney pathology is, I would say, variable, starting from either, well, light chain deposition diseases, heavy chain deposition diseases, mixed proliferative glomerulonephritis with monoclonal IgG deposits, CIF3, light chain proximal tubulopathy, and others. So we have like the whole portfolio of different changes. But first of all, we are looking for the depositions and proliferative glomerulonephritis.
Yes, definitely. And when we do have a pathology that indicates MGRS, and we think it's because of a clone, there are generally two options for clones. Either it's a plasma cell or it's a B lymphocyte.
Okay.
And of course, the treatment of these are not the same. With B lymphocyte, you would use rituximab or other B lymphocyte treatment, and with plasma cells, something that is used in multiple myeloma, like bortezomib, for example. So how do we know which one of these is the actual clone? How do we choose therapy for these patients?
Well, honestly, we do not have so many, I would say, possibilities to assess very precisely the clone. First of all, because, well, if we do have the data like light-free chains, so we think, okay, it might go for some kind of plasma dyscrasia. Okay, oncologists have the PET test. We are now doing on an everyday basis. In some doubts, we can use MRIs and also bone marrow aspiration biopsy. But honestly, it's not so easy. So that's why if we do have a suspicion, we generally ask our hematologist. Why? First of all, because we do not have any, I would say, possibilities to treat. So outside our hematologist, with rituximab, okay, we can do it, but with bortezomib, there is no such possibilities, unfortunately.
Yeah, so we have to collaborate with the hematologist, right? And they are part of this decision.
Absolutely.
And if it's an IgM antibody, we can assume probably it's a B lymphocyte. And if it's an
Yep.
IgG, probably it's a plasma cell, and we could go in that direction, right?
Absolutely. And honestly, with rituximab, well, right now we have, well, let's say in Poland, we do have the therapeutic program, but it's designed for vasculitis. So for any other reasons, if we would like to start with rituximab, which is right now, I would say, cost-friendly, let's put it this way. So we can, usually what we are doing, we're just informing the ethical commission that we would like to use, and of course with the informed consent of the patient.
Yeah, yeah. And then we can assess the success of therapy by using hematological criteria. That's one way. Of
Yes,
course, the drop in the monoclonal antibody, the drop in the kappa or lambda light chains, and this
absolutely.
usually correlates with the kidney, what's happening in the kidney. But in cases where you don't have a monoclonal antibody in the serum, you cannot use hematological criteria, right? Then you have to probably stick to nephrological criteria, maybe
Yeah,
a better kidney function, less proteinuria. How do you,
absolutely.
yeah. So
So
you go,
well, it's, I would say that our opportunities are quite limited because, well, for hematological criteria, okay, we can use the free lambda chains whatsoever and the levels. For renal part, what we are looking for, first of all, for the kidney functions is one point, and the second point is looking for proteinuria. If there is no proteinuria, also we can have a look at the albuminuria. So this is like on the much lower level.
yeah. And I've seen patients who have responded well to bortezomib and dexamethasone, perhaps cyclophosphamide, like a multiple myeloma therapy with
Yep.
a dramatic lowering of proteinuria, but then in some time it comes back, which is, of course, it makes sense. We're not capable of completely deleting the clone. So have you ever repeated treatment or maybe given some kind of maintenance therapy?
Well, I would tell that it's very individual, honestly, because, well, every patient is different, and in the elderly population, we are trying to be extremely careful
Mm,
because of infection problem. So
yes. Yeah.
on one side, we know that if we do not, I would say, prevent the clone from cloning or for progressing, this is one point. But on the other side, if it's a frail elderly, we are really afraid of infections complications.
Yes,
In
I have the
particular, after
same.
rituximab, because, well, all of us, we do know that after rituximab, there is a depletion of cells, and the infection problems could be let's say 3-4 months afterwards. And generally quite a lot of us just forget about the treatment at the time, in particular when patient is coming to a different outpatient clinic or a different department, and when the doctors will look at all the files, Well, well, that's okay. It was like 3 or 4 months ago. It was rituximab, 2 doses, and now we can experience some kind of related infections. And I would tell it's also not so obvious that in every, I would say, unit, internal medicine and nephrology, at the very beginning, we start with assessment of levels of immunoglobulin.
Yeah, yeah,
It's really crucial. Well, we got this experience mainly from the transplant patients,
yes.
where they
And
have some kind of a recurrence of different diseases.
some of these patients, you've mentioned older patients, and a lot of them are older, of course, but some of these patients are pretty young, in their 40s or 50s perhaps, and I've seen that some hematologists treat them with the bone marrow transplantation, not just in amyloidosis. In amyloidosis, it's more clear cut, but even in cases of proliferative glomerulonephritis, they treat with bone marrow transplantation, which is quite a serious therapy. Have you ever done that, or would you advocate
No,
that?
honestly, our hematologists, they didn't, as far as I know. We have a lot of experience with the patients after stem cell transplant, both allogenic and autogenic, because we have, I would say, a very good hematology department. It was high volume transplant program. They also use even the CAR T right now. And we are, I would say, very familiar with all the complications after stem cell transplant. And a part of this MGRS story, what we did see when we're asked for the consult, like I'm on the 6th floor, our hematologists are on the 1st floor, so it's just going 2 floors down. It's mainly the AKI within the first days after transplant. And of course, it depends upon the protocol. Were they using the conditioning, which kind of a conditioning, which kind of a drugs. So this is like AKI. And also we have problems with the toxicity of these different treatments, in particular when they use also the nephrotoxic antibiotics, plus antifungal drugs. Later on, what we did see, it's usually the graft versus host disease. Sometimes it also kidneys are involved, either in acute or chronic graft versus host. So we did even did some biopsies in these patients, and like we found generally or FSGS or minimal change. But the treatment is on the side of hematologist.
Yeah.
They use either calcineurin inhibitors. They also, and we experience in our common patients, they use ruxolitinib with, I would say, at the very beginning with a very, very good response. Later on, it was not, I would say, very effective treatment. So from the, I would say, consult part, we do see quite different complications afterwards. But we are fully aware that in the situation was a clear cut of like acute leukemia or lymphoma or so we just weighed the cost and the benefits.
Sure.
For MGRS, well, it's much more debatable. It's much more doubtful. It's much more individualized.
Yes, that's what we struggle with as well. Of course, graft versus host disease you would only get with allogenic bone marrow transplantation, and I guess in MGRS you would possibly go for an autologous
Like in
bone marrow
multiple myeloma.
transplant, but that one is still can be quite problematic in terms of outcomes.
Yeah, but generally, what I was told quite recently by our hematologist that they are so advanced in the new treatment for multiple myeloma using a combination Syberg plus daratumumab that probably even the idea of autologous stem cell transplant would be abandoned because of the results of this combined treatment are so promising.
Yes, yes.
That given the results with the daratumumab, probably they will stick to the idea that the transplant would be, I would say, the last refugium whatsoever if this treatment would be unsuccessful.
Yes, for sure. Yeah, daratumumab is really successful nowadays in AL amyloidosis as well.
Yeah.
So sometimes patients with monoclonal antibodies have signs of complement activation, like thrombotic microangiopathy. And then we have an issue how to treat this patient. So if the monoclonal antibody is causing this, one would want to treat the clone, right? But how do we know that the monoclonal antibody is causing this? It might be a coincidence. It's very difficult to decide to give anti-complement therapy or perhaps clonal therapy. How do you see this issue?
Well, I would say this is the most toughest part. Because, well, to treat the clone, we have to bear in mind that sometimes it's a price to pay. And that's why we might experience also drug-induced TMA. And it's extremely tough to decide, and it shouldn't be the one-person decision.
Yes, yes.
Rather, what we are doing, and I would tell that we're also fortunate enough that we have the, I would say, large hospital, university hospital with more 1,000 beds and different specialists. So what we are trying to do in particular a challenging cases like to meet like 5, 4, 6 sometimes people with different expertise, with a different background, and try to discuss the particular case and to make the decision as a group, as a multidisciplinary group. But what we did experience as well, that coming to the pure, well, I cannot see pure TMA, but just micro thrombotic angiopathy. In our country, we do have the therapeutic program with eculizumab and ravulizumab. We do not have any other opportunities. And there are very strict criteria to enter the program.
Yeah.
So from this perspective, from the perspective of a payer, we cannot go for this therapeutic program. Because we need to prove that is TMA, that we have to prove also all the other backgrounds, I would say, we have to put the checklist. But what I would like to add that even in patients with proved TMA, and even with certain genetic mutations, we tried eculizumab at the very first moment. It was in the kidney transplant recipients after like 6 months of very good, I would say, response and repeated kidney biopsy. There was no signs of thrombotic microangiopathy. Unfortunately, in the last biopsy, we did have TMA. And what I did learn from, I would say, from the consults abroad, that there are some patients who appear to be unresponsive to eculizumab and ravulizumab.
Yes.
And today we cannot offer anything else.
Yeah, yeah. But it's an
I know
evolving
they're
field,
just,
so maybe in time I'm sure in time we'll have more approaches available. So thank you very much. I completely agree. It's a difficult subject, and we actually started in Ljubljana our regular hematology and nephrology consult just because of these patients. And we try to learn from each other, and it's always easier when there are several people involved in the decision. So now we go to the last question, which is which book, 2 songs, and luxury item would you take to a desert island?
well, honestly,
Yes, honestly.
from the Polish songs, there is just one, which is which was written like let's say almost 100 years ago in Ireland, that time is passing so quickly and we can enjoy every day of our life.
Oh yeah, that's a good message, right?
This
That's
is
a
very
Polish song.
emotional song. This is song was written in Polish by the priest in Ireland, about that if the time is passing so quick. It was exactly at the time of Abitur was the final exam to finish the high school, which means the cutoff between being a teenager and mature person.
Yeah.
And I would say the longer you live, the more you appreciate the content of the song.
Oh,
And
yeah,
that's why it makes you, I would say, enjoy every time of your life.
Yeah, I sometimes think that we as doctors and obviously nurses as well, that one good thing about our profession is that you realize that nothing is guaranteed, that anything can happen very quickly. Nobody plans for a huge disease. Nobody has cancer written on their calendar for 2027 or whatever. So yeah, we have the luxury of knowing that we should enjoy. And how about the book and the luxury item?
For me, it's concerning the Polish stuff. It's Quo Vadis. Where are you going?
Oh yeah, the author is
Sure, you know Henryk Sienkiewicz.
Sienkiewicz. Yes, of
He won the
course.
Nobel Prize.
Yeah. Henryk
And this
Sienkiewicz.
is the story of Roman Empire.
Yeah, that's an interesting
So
one.
like more than 2000 years ago. And the message is we have to think about our way. Or are we heading? Where are we going? How about our life? And also, I think it's also the matter of age.
Yeah. Where are we going? That's a very tough question right now.
Oh yeah,
Definitely.
very, I would
And
say, complicated in generally situation.
complicated, definitely. And what's the luxury item that you would take to a desert island? Many people say a pillow, but there are different answers.
Well, it's quite difficult to tell, but a pillow it's a good idea.
It's a good idea.
Make you sleep well.
Yeah.
Or just something, some kind of, I don't know, say perfumes to make lives, I would say much more challenging to have something with a good memory. For me, like my beloved perfume is Wanted by Helena Rubinstein.
Okay.
This is the
I don't
very
know that
old.
one.
You know, Helena Rubinstein is rather known much more for cosmetics, but also she invented the perfume. She came from Krakow, then she went to Australia, and later on she landed up in US. And the second one is the Miss Dior.
Classic.
And as you know, it's also very historical background because Dior designed this particular perfume for his sister, and she was in the French resistance movement, and finally she got to the prison, and when she was liberated, it was kind of make the tribute what she's done during the wartime.
That's a nice tribute. Okay, that's great. Thank you very much, Jolanta. This was, I knew it was going to be a tough talk because it's a tough disease, but it's always refreshing to hear somebody else's perspective in treating this difficult subject. Thank you very much.
Thanks so much.